Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the School of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome Dr. Sandra Palavacino. You are a medical bariatrician and director of the Medical Weight Loss Program at TidalHealth. Thank you so much for coming.
And thank you for your invitation. This is great.
This is just such an important topic. You would like to talk about obesity and just helping people understand the causes and some of the approaches we can take. So I'll let you get started talking about what defines obesity and then what are some of the causes. Give us a background on it.
Absolutely. So about 2015, I got really interested on obesity as a disease. Before that, we didn't understand obesity so well, I have to say. In 2012, it was declared as a chronic disease. So for that, we need to look for how to prevent it, treat it, and so give rehabilitation to patients who have lost weight, such as any other chronic disease. So that rampaged a whole lot of research around why a body starts gaining fat weight or gains weight and how to prevent it, treat it, or help them not to regain it. So it's a very newer field in medicine, but even though we have been having surgeons treating obesity for over 50 years, the medical side is growing ever more after this new findings and discoveries about how the disease works. So since then, I've been practicing 100% my practice and trying to help patients lose weight.
Yes, because I see you're a medical bariatrician. I've had other bariatric physicians on, and they focus on the surgery part. So,
absolutely. So now we have team-up approach. In the future, obesity is a very complex disease. Such a complexity, such as, for example, cancer, where you have a surgical oncologist, medical oncologist, radiation oncologist, the nurses around it, the dietitians around it, the mental health. Obesity will be probably very similar. Nowadays, we already have multidisciplinary teams that work in the same building, dietitians, medical professionals like me, medical bariatricians, and the surgeons.
And I know we were chatting before the show that we're getting away from the BMI. Everyone hears about the BMI, and you can go online and calculate it. I mean, how do we now, or you say in the future, we're going to have different ways of determining obesity?
That's a very excellent question, very up to date with what's going on, because for years we've been using this body mass index, which is a calculation that uses your body weight and your height to give us an index, which is just a number. So it's easy for us to interpret what is your weight compared to your height, but it tells you nothing else about the person. It tells you it has nothing to do with age, gender, ethnicity, how active or not you are, what is your level of activity, how many medications you take, none of that. So it's being used right now to decide if somebody qualifies for the diagnosis or some of the therapies, but really tells you nothing else about the individual. So we have noticed that we can have a person with a very heavy BMI and still not have other complications like diabetes or hypertension, or we can have a slimmer patient who has very high sugars. So sometimes the BMI doesn't really reflect the level of impact that the disease is having in the person. So in the future, we focus more on very simple measurements like your waistline or where is the weight located. In our clinic, for example, we use a body composition scale, which gives me much more information about from this body, how much is fat tissue, how much is lean tissue, and is this somebody who has a concentrated fat in the middle of the body. Those are the type of cells that will create more trouble in the metabolic side. They're more active in the endocrinology way, so they'll create more complications such as diabetes, heart disease, even Alzheimer's, and 13 different types of cancers now.
Right, I know I've been reading that for quite some time, that central obesity is more concerning.
Absolutely. So the measure of your waistline can give you much more information than just a plain BMI.
So let's get back to talking about what are some of the causes of obesity or some theories behind, why it happens to some people. It seems so much easier than others.
Absolutely. So the same way that other chronic disease come upon a human, it's not something we want to have or we desire to have, right? So humans could become or develop obesity in each stage of their life. But some of us will have it since childhood. And then some other humans will develop later in life. Normally, I see them associated with times in your life that you have gained a lot of weight in a short period of time. For a lot of women, it's pregnancy or maybe after menopause. Other patients could be secondary to medications. Other patients could be, so there are medications out there that we prescribe for diabetes or heart disease or depression that could cause obesity as a secondary side effect. There are other conditions that are hormonal that could cause weight gain, and one person can have them all at the same time. Somebody can have insulin resistance and hypothyroidism in the one person. So what I'm trying to explain is that obesity is a multifactorial disease. About 80% of the United States population is associated with an underlying hormonal condition. Out of the hormones that are mostly associated with weight gain is insulin, but there's others like thyroid or cortisol. And also the decline of ovarian hormones as we get to menopause is also another hormonal problem. But besides that, there are drug side effects, patients coming out of other addictions such as smoking or alcohol, they could gain weight. So it's very multifactorial. You need to analyze all these aspects in order to give somebody a
You mentioned cortisol.
idea.
And I have always read that when people are under stress, they put out more cortisol, and that tends to lead to some central obesity. So that being under stress is problematic. That affects blood pressure. It all seems intertwined.
Because it's all basically metabolic syndrome. Cortisol. So if you have Cushing's, which is a tumor that makes cortisol, is very different than the cortisol that you're talking about, which is the chronic, either related to financial stress or personal stress, or even the one is more real, like chronic pain or not untreated sleep apnea. All these patients could have high levels of cortisol, and through insulin, it will create the increased abdominal fat. And the difference between Cushing's is that those levels of cortisol, you're not going to be able to measure them, like having a number. And what we advocate for is trying to sleep, trying to avoid sleep deprivation, etc., calm your stress, treat your pain. But in our country, for example, in all industries, we have night shifts, not only in the medical nursing, first responders, but also Walmart or insurance companies. They have people awake on all hours of the day. So the incidence of weight gain and obesity in this group is very high through cortisol, like you were saying.
Yes. And I mean, would you also say it's just so much more prevalent now, partly because we're just not as active overall, and our diets are different, with a lot of fast food being available versus when I was growing up,
You're right. So, but in my personal point of view, after reading tons of research, and not only that, but practicing for 7 to 8 years and interviewing like sometimes 20 patients a day, you start getting a sense that a lot of patients that have the disease of obesity or suffer of obesity, they can still be very active. You can still have marathon runners, they still have the condition. So if the underlying disease that is causing most of your weight gain is, for example, insulin resistant, you could be an athlete and still have an excess of weight. But in your question, which is why there's more prevalence now than maybe 20 or 30 years ago, the food is important. And not only the food, but what's being done to our food.
Right.
So like you were saying, now we are in an era of everything needs to be immediate or fast, so we will have much more processed food, and food that is being added ingredients for different reasons, just to make it more palatable sometimes or last longer. And we still don't understand all of them completely, but definitely they play a role. But the other thing is that we have developed this type of food are culprit of more insulin resistance. So the more insulin resistant our population gets, the more obesity we're going to observe, or patients suffering from obesity. So changing the food is still going to be very important. And also, we do stimulate patients to be physically active, but for many other reasons. Most of us will not lose that much weight just being more active. We need to change the diet, but definitely if you want to live forever and you want to be independent forever, exercise will definitely be important.
Yes.
So we always advocate for that. But in my line of work, the understanding that whatever you consume every day, 3 or 4 times a day, is one of the most important things you need to change.
That's why it's so important. I mean, we wanted to talk a little bit about the addiction piece of things. And I always say, you know, if you want to quit smoking or drinking or drugs, you know, you just stop. Food, you have to keep eating 3 or 4 times a day.
Absolutely.
So it's a lot more complicated to learn how to
It's
change
more
your
complicated
habits.
because for food, you need to make hundreds of decisions every day. Hundreds of yeses or noses or maybes, and you know. So it's true that cutting alcohol or cigarettes is very hard. Otherwise, people would not do it. Obviously, it's very hard to quit. But humans can live without alcohol or without cigarettes forever. So some of us never did
Right.
either.
That's what I meant to imply.
Yes,
Not that they're easy addictions, but
they just need to maybe don't stop at the bar. But food is the forever thing. You have to make tons of decisions, and you don't until you understand how your brain is making those decisions and who is driving. And that's what I will explain the addiction piece.
Right.
It's like somebody else is driving for you. So because my patients will come to I will disclose that we do screen for food addiction and sugar addiction in my office. I'm about to get statistics, but I will, in general, say about 30% of patients with insulin resistance do also have obesity and food or sugar addiction or processed food addiction. So the way I make them understand, because these are very accomplished patients, they're very smart, there's nothing to do with their intellect. This is another circuit that's going on in the brain because the food they receive, they're addicted to, makes the brain just light up just like any other drug. So it's like you're driving and then you have somebody on your side telling you what to do, turn here, you know, like stop, be careful. And at some point you're like, okay, why don't you drive? Because you seem to know better. So when you let it go and the addictive circuits are going, dopamine in all of them, it's like you're not awake. So patients will end up eating certain things and they will tell me later, I knew better. Why did I do that? So in the moment, it's a separate part of the brain that is actually causing, same as in alcohol and same as in cigarettes or other drugs, to the point that takes over. So you need to regain the driving seat and understand how to deal with that.
I know this is very complex and there's a lot to talk about, but maybe just give us an overview then of what happens when someone comes to your office. They don't need a primary doctor to refer them or provider. They can just call and make an appointment or go online. And so what is your plan? You do an assessment, obviously, and then what are some of the strategies you would suggest as a medical bariatric
Right, so our
physician?
first appointment is normally very lengthy because we want to know everything that's how do you gain the weight? We normally do the history of weight. We start from whenever the patient feels like been gaining weight, and we go and build it up from there. A lot of our patients have attempted weight loss, what worked, what didn't work. We also want to know their past medical history, their family history, the medications they're being on, how do they react to those medications. We screen them for sleep apnea. We screen them for food addiction. We do measure them. We do measure their BMI still. We do the body composition scale and analyze it for them. And we do want to do a food diet. I mean, it's short because you're in my office and I'm asking you, what do you be eating for all your life for breakfast, lunch, and dinner? But we try to tailor it down to the last few years, and patients kind of give me an idea what they're eating, when they're eating, what time are they eating it, why they're eating that, do you know how to cook, where you live. All these factors are very important because if I give somebody a list of food, and these patients don't even have a kitchen sometimes, so you have to understand the whole component, the physical activity, what is your level of capacity for physical activity, etc. So after all of that's done, initially I normally decide which blood work is necessary to continue the program, or if they already did it with their primary care providers, we will look at the results and then look at everything that impacts the nutrition, the metabolic panels, cholesterol, electrolytes, kidney function. So with all that, we'll decide diabetes, sugars, we decide what will be the next step on the nutrition, which is my main issue. So as a medical bariatrician, 90% of my time I'm going to be talking to you about what changes in the diet will be, in my opinion, best for you or not. And I tell my patients that the initial appointment, I'm going to give you a dietary plan that it could change with time. in the future you will tell me, you give me a feedback. This worked, this didn't work, I like, didn't like, this give me this symptom, and then we'll continue. There's not one diet for everybody, definitely not. And then we discuss other things during that first appointment, like, for example, are you using any medication that is causing you to gain weight or retain weight? Sometimes we identify them, but we cannot stop them because, they're using it for breast cancer treatment or something. So we will just make the patient aware that that's another challenge. And if there are medication they can use that can help them with weight loss, or could they be a candidate for bariatric surgery? All these discussions come during that appointment.
So what about the newer meds now that are out, and some of which they're used for diabetes, but they're also approved for weight loss? What are your thoughts on that? Because I imagine there's more coming down the pike because they seem to be very popular.
This is a new wave of science. Obviously, we understand obesity as like I will explain, it's a multi-factor disease that is associated with many other conditions. So, not surprisingly, I've been for the last 7 years explaining that the gaining of the abdominal weight, diabetes, non-alcoholic fatty liver disease, which right now just changed its name to metabolically associated disease of the liver, PCOS, infertility in the young woman, hyperlipidemia or high cholesterol, cardiovascular disease, including congestive heart failure with a preserved ejection fraction, you name it, Alzheimer's, 13 different types of cancers, including postmenopausal breast cancer and colon cancer. All of them are going to be, at the end, the same disease. So if a drug is good for diabetes, it's going to be good for obesity. It's going to, in the future, the same drugs that you're mentioning or that we're going to talk about next are going to have indications in cardiology, neurology, and GI diseases. And not because there are super drugs that treat every disease. It's because all of them are the same. It's a metabolic it's a metabolic disease that affects the cells to the level of how the cells uses the energy. So for right now, we've been using these medications as for diabetes, like sugar control. But what happened is that patients were also losing weight. So now they got approved for weight loss even if you don't have diabetes yet. But this is for me to explain to my colleagues and whoever wants to listen that this was the same disease to begin with. Some of us, like cancer, right? So you have, some of them have metastatic disease or different levels of the cancer. This is the same. You can have obesity with or without diabetes and you're still treating the same disease. You can have obesity with or without fatty liver disease or without diabetes, and it's all still going to be the same. And in the future, in that group, gout, Alzheimer's, and 13 different types of cancer are going to be in the same. So technically, these medications will be used for many things in the near future, and that's why you see more of them coming down the pipe.
Well, it just seems so important for people to try to address the weight problem and to eat better along the way and keep moving. They're all positive things. And I guess the first step is realizing you have an issue and coming to see you.
Oh my gosh, thank you so much for saying
No
that.
problem.
Because not the part that coming to see me, but the part that we need to realize there's something in there, because there's been different understandings of what weight gain seems in different generations. Maybe in our previous generation, everything was about weight, and weight mean that you may not be the most successful person in life, which has nothing to do with it. But it was an understanding, so this generation needed to all be very thin, and they're all looking for a number on the scale. Then it's the new generation that is understanding that all bodies should be accepted, and we all need to, that somebody has a different body type doesn't mean they're less smart or they cannot do a job properly, which is obviously is appropriate. But what I don't want is the patients to miss that if you're having a problem with weight, even though nowadays we accept it, we all work together, there could be something in there that we may need to address to prevent future complications.
Right, it's a health issue, and I know I went to some seminars of late where they talked about that. Doctors and providers have to be more comfortable saying, this is about health, just like smoking, and other habits that aren't conducive, to
Absolutely.
good
That's
health.
why we're trying to go away from body mass index, because only tells you about their weight. Doesn't tell you what else is going on. So that's important.
That sounds really like a great strategy. So your office is located in Seaford.
Yes.
And people can call and make an appointment or go online, and we'll provide the TidalHealth website at the end of the program. What about insurance? Does insurance cover these kind of visits?
Sure. Since many years ago, when, like I'm saying, obesity is considered a chronic disease, Medicare was the first insurance who decided that they were going to provide coverage for patients trying to look for help with providers like me, or depending on your comorbidities with some of the dietitians. So they will cover those visits. And then after that, all insurances, as long as we are having a plan for the patient and we document, they will get their insurance, will cover the visits. Now, the medication and the surgeries also are covered by insurance. For most of the insurance, they cover 100% of the procedures. The medications is like a new world, so not all insurances are covering medications.
They're probably behind the 8 ball on that.
Exactly.
They haven't quite come into...
They haven't come in. And they're very expensive drugs, and I only see in the future they'll have to make a decisions about which one, but at least give the patient some options.
So someone that sees you and they get a lot of medical intervention and nutritional interventions and so forth, there may come a time where surgery might have to be considered and they would get a referral for a bariatric procedure.
Absolutely. So even our primary cares around this area are very well informed of who will qualify for surgery. So sometimes the patients come directly to the surgical program from their primary care providers or other physicians if they qualify. So in the new programs that exist right now, which we are like combined, patients will come to us for the pre-op nutrition and the post-op nutrition, and then go get their surgery, and then there will be our patients for lifelong, right? Because we need to continue to address it's like you have in any other chronic disease, you'll see your doctors forever. So that's the magic of the combined groups, because you have all the interdisciplinary knowledge to help you with your condition. And it has happened that some patients come very inspired to have their surgery, and all of a sudden they're in their pre-op program, they're losing significant amount of weight, and they delay the surgery. That could happen. Or the opposite, like you said, sometimes the patients come and they insist in non-surgery, and we will maybe get to the point that we need to rediscuss this and then seek for the expertise of the surgeons, and then go with that procedure, and then come back for the rest of the nutrition.
And surgery is just a tool. They have to continue healthy eating habits after, because the stomach is much smaller. And
so definitely surgeries, especially the surgeries they do nowadays, they're considered metabolic surgeries, because they not only give you the mechanical restriction, they also change a lot of hormones. That's how we discover those new medications that we're using now, based on research on patients who had success with bariatric surgery and try to mimic, right? So bariatric surgery has been instrumental in the understanding of how the hormones inside the body are the ones who decide who's going to gain weight and who's not, and who's going to be full, who's going to be satisfied after their meal, who's going to be still hungry. So those are things that are beyond our conscious mind that is happening in the body, and thanks to a lot of the patients who went through bariatric surgery, we learn a lot of that.
Right.
So now we have options, non-surgical options, but bariatric procedures are still going to be a big tool in the treatment of obesity. It's just not my field. I just support the surgeons, the patients pre and post surgery, to make sure that they just got the surgery and don't have any more support. We provide support all throughout.
Well, it sounds like your medical focus is an important piece of the puzzle.
Finally, we got
right,
around.
I know. So thank you so much for coming on the program and explaining all these very important concepts about obesity and strategies and so forth. I think it's very beneficial.
Sure. As you can see, I'm very passionate about understanding this new condition, explain it to patients and providers, colleagues of mine, and also continue to learn. If something that I said to you changes, believe me, I'll be back and tell you more, because this is a growing field. As I'm telling you, we've just had a change in the name from one of the complications on the liver, and I see this continue to progress that way.
Yeah, I see terminology evolving too.
Terminology, diagnostic criteria, all of that.
Right. Well, thank you so much.
Great, fantastic to be here.
And thank you for joining us for this edition of Focus on Health here on PAC 14.